Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, we're doing another Kahoot, and we're going to be going over maternity. We're going to be going over important drugs that you need to know for maternity. So if you're studying OB right now, I came right in time. Even if you're not studying OB, if you're studying for boards, these are important drugs that you need to know. So pay very close attention. Before we get started, as always, I'm going to ask you to please support me and support this channel by liking this video. You're gonna love it. Go ahead and give it a thumbs up now. Subscribe to my channel if you have done so already, and be sure to check out my website, nexusnursinginstitute.com. I have plenty of resources available on my website. You can sign up for Next Generation NCLEX review session, part one and part two. In part one, I teach you how to think critically. I teach you about prioritization and delegation and different scenarios that NCLEX will present to you and where your mind is supposed to go. In part two, we go over NCLEX type questions, rationales, with how you need to apply them to the type of questions that you get. You can sign up for a private tutoring session. If you want one-on-one tutoring with me, you can sign up for that. You can sign up for a consultation session. Maybe you want to pick my brain about something, you want some advice that has something to do with the nursing arena. If you're a current student and you're not doing well, you have to do really, really well on your next exam to even stay in the program. Check out the audio lessons I have available. See if I have an audio lesson that matches an upcoming exam that you're going to be taking. Very soon coming down the pipeline, I will be introducing the Nexus Nursing NCLEX Text Bank, and that's going to go over the most important things that you need to know for NCLEX in question format, in the next generation NCLEX type format, as well as the traditional format that's coming down the pipeline. So watch out for that. Lots of great resources. Again, nexusnursinginstitute.com. Almost daily, you can find me covering a variety of nursing topics across my social media platforms: TikTok, Instagram, Facebook, YouTube. Right here on YouTube, my handle is the same everywhere, Nexus Nursing. So be sure to check me out. All right, guys, without any further ado, let's get started. Maternity pharmacology. First question, select all that apply. Which instructions would you include in discharge teaching for a patient that received methotrexate for an ectopic pregnancy? Here are your options. Avoid sexual intercourse until HCG levels return to normal. Take folic acid supplements daily to promote healing. Avoid consuming alcohol while undergoing methotrexate therapy. Return for follow-up visits to monitor HCG levels. Avoid NSAIDs while on methotrexate. Avoid getting urine on the toilet seat, and double flush with toilet lid down. Select all that apply. What are you going to teach this patient that is getting methotrexate after an ectopic pregnancy? Is this better, guys? Okay. Everything except for blue. So let's talk about what you're not going to teach them. Then I'll go over the correct answer. You are not going to tell them to take folic acid supplements daily. You tell women who are pregnant, who actually has that fetus growing and they want it to grow, you're going to tell them to go ahead and have folic acid. It helps with development and CNS. But this person just had an ectopic pregnancy. Methotrexate is the antagonist of folic acid. So why in the world would you tell them to take folic acid? That is wrong, okay? Everything else is right. You're going to tell them to avoid sexual intercourse until those HCG levels have gone down to normal. We don't want them to get pregnant during this time. They may have developed scar tissue. This patient has to be assessed. This is not the time to be getting pregnant. Of course, we're going to tell them to avoid consuming alcohol while they're on methotrexate. They shouldn't be drinking alcohol while they're on any medications. That's across the board. They need to avoid NSAIDs while on this medication. We don't want any bleeding issues. And we're going to have them keep coming in, returning, because we're going to be checking the HCG levels. We need to make sure it goes down to normal. And avoid getting urine on the toilet seat and double flush with the toilet lid down. That is absolutely true. This drug is so toxic. We don't want it to be aerosolized at all. Okay, I'm going to go more into detail about this drug, but that absolutely is one of the things you're going to teach the woman. Next question. True or false? Methotrexate is a hazardous drug and can cause serious toxic effects even at low doses. Is this true or is this false? I'm sorry, I accidentally gave you the answer. Sorry about that. Is this drug toxic even at low doses? True or false? All right, let me move it closer for you. Maybe that'll help. True. This drug is very, very, very. Let me tell you how. Let me tell you how toxic this drug is. We take this drug very seriously. You have to be very careful. The pharmacist in the pharmacy is the one that has to prepare this drug and prepare that dosage, not the nurse. That's number one. When the pharmacist has that drug in the syringe has to be in a plastic bag. Needle cannot be in that bag. It's going to be separate. That's number two. When the nurse actually gives this medication, you know how you put on gloves when you're going to give an injection? Guess what? You have to put on two gloves. You got a double glove. Uh-huh. Number three. Am I on number three? Number four? I don't remember. But something else you got to know about this drug. You know how you want to prime or expel air out of the syringe? You cannot with this drug. We cannot have this medication aerosolized at all. When you get rid, after you give this drug, you don't just put that syringe in, trash. It has to go in a hazardous wastebasket. Hazardous, okay? This drug can be very, very, very toxic. You have to be very careful. All right. Which statement from a patient taking methotrexate for rheumatoid arthritis requires further teaching? Is it, I should stop taking methotrexate at least 3 months before trying to conceive? Is it, I'll need to use a reliable form of birth control while I'm taking methotrexate? Is it, if I get pregnant, I'll continue to take it until my first prenatal visit? Or is it methotrexate can cause serious birth defects if taken during pregnancy? Which statement would require further teaching? Very good. Most of you guys got it correct. If she says, oh, if I get pregnant, I'll continue taking this drug until my first prenatal visit, you're going to have to do some teaching with this patient. This drug is a category X drug. It is teratogenic. You get pregnant while you're taking this drug and you continue taking that drug, you're going to mess around and have a fetus with 12 eyeballs, okay? It is very, very teratogenic. The fetus will have birth defects, okay? Everything else is correct. I should stop taking methotrexate at least 3 months before trying to conceive. Yes, we need to make sure that drug is completely out of your system before you even think about getting pregnant. I'll use a reliable form of birth control while I'm taking methotrexate. Yes, because we understand it's a category X drug. You cannot get pregnant while taking this drug. And you understand that it can cause serious birth defects if taken during pregnancy. Okay? Your patient's receiving magnesium sulfate for severe preeclampsia. Which finding would require immediate action? Would it be a respiratory rate of 10 breaths per minute? Would it be deep tendon reflexes of +2? Would it be a urine output of 40 milliliters per hour? Or would it be a blood pressure of 150/90? What do you guys think? If you guys are not in the Kahoot, you can still participate. Just type in your answer on the live. Okay, very good. Respiratory rate of 10 breaths per minute. So guys, what is the minimum that the respiratory rate should be? You guys on the live, tell me, what is the minimum? What number? Quickly. Thank you. 12. 12. Think about it. This drug, first of all, let me point something out to you guys. Whenever you guys get a test question and they give you a diagnosis and they give you a medication and they ask you what you're going to be concerned about, what you're going to do, the question is always about the medication. Don't get distracted by the diagnosis. So this question says your patient receiving magnesium sulfate for preeclampsia. Your answer, what you're going to be concerned about, is not going to be associated with the preeclampsia. It's going to be associated with the magnesium. Think about it this way. If they mention a drug that you are about to give or that you just gave, it's a drug that's going to change something chemically in the patient's body, not the disease. They already have the disease, right? So you're concerned about that medication you're either about to give or you just gave. Questions like this are very misleading because a lot of students will see preeclampsia and they'll try to find an answer that has to do with preeclampsia. Forget that. That's not what we care about. We care about the drug. We care about magnesium sulfate. So when you see this question, you got to say to yourself, okay, what do I know about magnesium sulfate? Okay, well, I know magnesium sulfate will cause relaxation of the muscles, right? It can cause relaxation of the muscles. It can, relax things. Well, what happens if it works a little bit too well, right? Those respiratory muscles relax a little bit too well. Boom, decreased respiratory rate. Deep tendon reflexes of +2, that's normal. I'm not concerned about that. Urine output of 40 mLs per hour, that's normal. You should have at least 30 mLs per hour, right? So I'm not concerned about that. That blood pressure of 150/90, I'm happy only 8 people got tricked by that. I was hoping I'd get more of you. But yes, that is an elevated blood pressure. Yes, it's not normal, but it's not as deadly as that respiratory rate. Whenever you get a question that's asking about to prioritize, right? And you have 2 answers. Both of them are abnormal and you can't figure out which one to choose. Say to yourself, which one will kill my patient the fastest? Which one is the deadliest? 150/90, yeah, slightly increased is not going to kill you, but respiratory rate of 10, don't even play. Can you live without breathing? Absolutely not. How are you guys doing on the live? Eris said, period, professor. All right, next question. If magnesium toxicity is suspected, what should be your first nursing action? Are you going to call the healthcare provider? Are you going to administer the antidote calcium gluconate or calcium chloride? Are you going to discontinue the magnesium? Are you going to increase the flow rate of magnesium? What are you going to do? If you suspect magnesium toxicity, what is your first action going to be? Very good. Most of you guys chose the correct answer, discontinue the magnesium, but I'm kind of concerned that 21 of you went with administering the antidote. So let me get this right, because I'm going to walk you through this. When you guys choose these kind of answers, I want you to see what you're telling the test writer. So for 21 of you that said you're going to give the antidote, what you're telling me, the test writer, is that you recognize this patient's getting way too much magnesium. You recognize that this magnesium is harming your patient, it's killing your patient. And while that poison is still infusing into your patient, you're giving them the antidote. What is that antidote going to do if it's still infusing into the patient? I'm telling you right now, whenever you get a test question about something that's harming your patient, every single day of the week, the first thing you are always going to do is stop the infusion. Whatever's harming your patient, you stop it first before you give an antidote, before you assess them, before you give them oxygen or fluids, before you do anything else, you stop what's harming your patient. Does that make sense? Are you guys with me? You picking up what I'm putting down? Okay. The screen is cut out. It looks like it's saying continue the magnesium. Oh, I'm sorry, guys. I don't know how to fix this for you. I'm sorry. Call the healthcare provider. 2 of you guys chose this. So let me talk to you about this. Before you're tempted to click on that answer choice of call the healthcare provider, look at your other options. Say to yourself, Can I do any of these for my patient before I pick up to call the healthcare provider? Right? So you see that you suspect your patient's going through magnesium toxicity. Let's talk about this because you got to know what those signs and symptoms are. Your patient's, excuse me, your patient's getting magnesium. You better be watching out for decreased respirations, lethargy, confusion, slurred speech, decreased deep tendon reflexes, right? Those signs and symptoms of magnesium toxicity. If you note that, you don't need to call the healthcare provider to stop what's harming them, right? Look at the other option, administer the antidote. Guess what? If you have that as an option, the antidote, it's been ordered. What are you going to do? Call the healthcare provider and say, hey, this patient's going through magnesium toxicity. I know you ordered it because I have the order for the antidote right here, but I'm calling you just to double check. No, you're delaying care. You're letting your patient die. Absolutely not. And one person chose increase the flow rate of magnesium. Yeah, you're getting your license snatched, honey. I'm so sorry to tell you that. You see your patients going through magnesium toxicity, which means that they're getting a lethal dose, and your bright idea is to go ahead and increase the flow rate? Absolutely not. No. We want to keep our patient alive, right? We're going to, number one, stop that infusion. Number two, give the antidote, which is either calcium gluconate or calcium chloride. Number three, assess the patient, get vitals. So when you call the doctor to say what's going on, you actually have something to say. Does that make sense, guys? Why are you guys laughing at me on the live? All right, let's keep going. All right, what drug is a drug of choice to treat eclamptic seizures and prevent repeated seizures? Here are your options: hydralazine, labetalol, methyldopa, or magnesium sulfate. I'll repeat the question. Which drug is a drug of choice to treat eclamptic seizures and to prevent repeated seizures? Is it hydralazine, labetalol, methyldopa, or magnesium sulfate? Very good. Magnesium sulfate. Professor D, do I need to know that? Absolutely. I promise you're going to see that as a test question somewhere within your academic career. You need to know this, okay? When it comes to treating eclamptic seizures and preventing repeat seizures, it's magnesium sulfate. Let me tell you something. Lots of students, another question you very likely may get is, what is the purpose of giving magnesium sulfate? I'm telling you right now. I'll tell you what the purpose never is: to bring down the blood pressure. Why? Magnesium sulfate has so many adverse effects. We have lots of drugs on the market to bring down the blood pressure. If the patient just happens to be hypertensive, and we need to bring down the blood pressure, we can give them hydralazine. We can give them labetalol as long as they don't have asthma. When it comes to labetalol, if the patient has asthma, they've got bronchitis, they've got emphysema, they have some type of respiratory condition, you're not going to give them labetalol. But other than that, you can give them labetalol. Methyldopa, that's to treat hypertension during pregnancy, right? There's so many drugs on the market that can bring down the blood pressure without the adverse effects. We will never give magnesium sulfate just to bring down the blood pressure. Magnesium sulfate, those are the big guns. We're giving magnesium sulfate to prevent eclampsia, the eclampsia seizures, or if the patient already had eclamptic seizures, we don't want it to happen again. That's when we give magnesium sulfate. You guys got to know the difference. I promise you'll get at least one text question on it. Okay? All right. I talked to you about everything I want to say about the screen. Let's move on. How are you guys doing on the live? What's the pin? The pin to get in is 857-6446. 857-6446. Guys, can you type in the pin on the live for me, please? All right, let's keep going. LaShonda Harvey, it won't let me into the Kahoot. You know what, LaShonda, I'm sorry. If you guys can't get into the Kahoot, this Kahoot got flagged right before I started the Kahoot, and I did the thing. I forget what it's called, but I did the thing where you say, there's nothing wrong with the Kahoot I'm teaching. I don't know if it went through or not. I did like a petition. Try to get in. Let me know if you get in. 857-6446. All right, next question. If you can't get in, just participate on the live. Blank is a corticosteroid that's used in pregnancy, and I can't even read. Let me start over. Blank is a corticosteroid used in pregnant women at risk for preterm delivery. It promotes lung development. What do we talk about? Is it betamethasone? Is it nifedipine? Is it calcium gluconate? Or is it calcium chloride? Which medication is a corticosteroid that's used in pregnant women who are at risk for preterm delivery? This drug helps to promote lung development. What are we talking about? Very good. Betamethasone. What you expect to be ordered, guys, is either going to be betamethasone or dexamethasone. Okay, those two are the corticosteroids that we give to women who are at risk for preterm delivery. We want to make sure that the fetus's lungs is developed so they will actually survive outside of the womb. So we'll give this to anyone that's at risk that's less than 34 weeks pregnant. You need to know that. Nifedipine, of course, you guys know that is an antihypertensive agent. It ends in pene, so we know it's a calcium channel blocker. And the last two, calcium gluconate and calcium chloride, I talked about those already. Those are antidotes to what? Magnesium toxicity. Your patient's going through magnesium toxicity, you have to give them an antidote. Those are the two antidotes, one or the other. All right, select all that apply. Which of the following maternal side effects should you monitor for during corticosteroid therapy? So we just talked about this drug. You give it to the patient. What are you going to monitor for? Here are your options: hyperglycemia, hypotension, facial flushing, increased WBCs, insomnia, and xerostomia. Which of the following maternal side effects should you monitor for during corticosteroid therapy? Hyperglycemia, hypotension, facial flushing, increased WBCs, insomnia, xerostomia. What do you guys think? That's okay, Giselle. Keep going. This is interesting. Let's talk about it. Hyperglycemia, absolutely. Let me tell you something. When it comes to corticosteroids, if we don't know anything about corticosteroids, there are four things we know for sure, beyond a shadow of a doubt. It doesn't matter what kind of corticosteroid. If it's a corticosteroid, number one, hyperglycemia. Corticosteroids are very sugary. It can cause hyperglycemia. Number two, stomach ulcers. Corticosteroids are very hard on the stomach. That's why we never give it on an empty stomach. You'll mess around and give the patient an ulcer. God forbid it becomes a bleeding ulcer. Number three, what's the third thing we need to know about steroids? Infection. Yeah, steroids can mask the signs and symptoms of infection. You have to watch your patient a lot closer. You got to watch the temperature. You got to watch the ESR. You got to watch the CRP. You got to watch the WBCs. Steroids can cause leukocytosis. You can see an elevation in WBCs. And the fourth thing you got to know about steroids is they can cause the bone to be porous, right? So we're going to be concerned about safety. Steroids will mess around and cause your patient to have what's that condition when your bones are porous? Osteo. Oh my gosh, guys, what's that condition when your bones are porous? Osteoporosis. Thank you. You mess around and have osteoporosis. We're concerned about safety. We're concerned about falls. If you don't know anything about steroids, know those four things about steroids that I just said to you. But anyway, I digress. So hyperglycemia, yes. Hypotension, no. If anything, steroids can possibly cause hypertension, can cause the blood pressure to go up. So no on hypotension. Facial flushing, no. We see facial flushing more with drugs such as vasodilators. Increased WBCs, yes. Leukocytosis absolutely is a possible side effect. Insomnia, absolutely. Corticosteroids can cause what? CNS stimulation. Yeah. And xerostomia, what's xerostomia, guys, on the live? Can you tell me what xerostomia is? Very good. Dry mouth. No. Corticosteroid doesn't cause xerostomia. Drugs like anticholinergic agents or antihistamines, some antidepressants, they can cause xerostomia, but corticosteroids do not cause xerostomia. So yes, on the hyperglycemia, the increased WBCs, and the insomnia. Select all that apply. Immediate birth is indicated if any of the following complications happen. Select all that apply. Here are your options. Imminent or actual eclampsia, uncontrolled severe hypertension, pulmonary, oh, it's supposed to be edema. I spelled that wrong. Sorry. Pulmonary edema, placental abruption, evidence of non-reassuring fetal status, fetal demise. So select all that apply. In what condition would immediate birth be indicated? Mom's going to have to go into labor. That baby's got to come out. What situation? Here are your options. Imminent or actual eclampsia, uncontrolled severe hypertension, pulmonary edema, placental abruption, evidence of non-reassuring fetal status, fetal demise. Only 12 of you guys chose pulmonary edema. Let me ask you something. Are you ever supposed to have fluid in your lungs? Are you ever supposed to have swelling of your lungs? Absolutely not. If you can't breathe, nothing else matters. You're dead. Right? All of these are medical emergencies. All of these are indications for immediate labor. Immediately. Imminent or actual eclampsia. What does that mean? Mom goes into seizures. Look at the next one. Uncontrollable severe hypertension. Did I spell severe wrong? S-E. Oh, I said server. Sorry, guys. Uncontrollable severe hypertension. First of all, the word uncontrollable should have been a red flag to you. And if you didn't catch that, severe should have been a red flag to you. Come on now. That absolutely is a medical emergency. Next, pulmonary edema. If you cannot breathe, nothing else matters. Absolutely. Placental abruption. Patient has placental abruption. Immediately, they're having a C-section. Immediate labor. We got to take care of that. Okay, that patient can bleed out. Evidence of non-reassuring. You have reassuring status and non-reassuring status. Non-reassuring status is bad. Immediate labor, and of course, fetal demise. That means that the fetus is no longer, I don't even know the politically correct term we're using these days, but you know what I mean. Viable is no longer viable. Okay, it's in the womb. If it stays in the womb, you want to know what happens to mom? She turns septic. All right, after an evacuation of the uterus, what is expected to be ordered to prevent hemorrhage? Here are your options. Oxytocin, a hemorrhagectomy, analgesics, or opioid narcotics. After an evacuation of the uterus, what is expected to be ordered to prevent hemorrhage? Very good. Most of you guys chose the correct answer. Oxytocin, oxytocin that causes muscle contraction, right? And so decrease the risk of hemorrhage. Guys, on the live, one of the options I made up, it's not a real word, it's not a real condition, it's not a real intervention. Which one did I make up? Can you tell me which one I made up? Not Pitocin. Pitocin's oxytocin. Yes, hemorrhagectomy. I made that up. It's not a real thing. Ectomy means removal of. Hemorrhage, removal of. So I just put that in there because I knew at least one person would see the word hemorrhage and say, "Oh, this must be the answer." Nope, gotcha. And the last two, analgesics, opioids. Analgesics help reduce pain, and opioid narcotics, those are a type of analgesic, so that's not the answer. So if after there's been evacuation of the uterus and you want to control the bleeding, you don't want the patient to bleed out, we expect oxytocin to be ordered. That causes uterus contractions. Okay, the muscle will start to contract and decrease the risk of bleeding out. True or false? The action of terbutaline is to promote contractions and induce labor. Is this true or is this false? Terbutaline. Is terbutaline given to promote contractions and induce labor? Is it true or false? You guys are doing great on the live. Very good. False. It does the opposite, guys. This is a beta adrenergic agonist, and what it does is it stops preterm labor. It stops those contractions. Okay. Two important things you guys have to know about this particular drug. It can cause maternal tachycardia and hyperglycemia. So you're going to be watching out for those, okay? Last question. Select all that apply. What are important side effects and adverse effects to know about terbutaline? So I'm asking about both side effects and adverse effects. Here are the options: tremors, jitteriness, tachycardia, chest pain, dyspnea, shortness of breath. While you're choosing your answers, let me make it clear there is a difference between side effect and adverse effect. Very often we use it interchangeably, but they are not the same thing. Side effect are things that may possibly happen. We warn the patient that it can happen. We're not going to change the med. We don't expect the doctor to change the med, the dosage, anything, but we warn them so they're not caught off guard. Adverse effect are things that can possibly happen that we warn them can happen, and we tell them if it happens to let us know right away. Why? Because we expect the healthcare provider, because it's so bad, we expect the healthcare provider to either change the drug, change the dosage, change something. That's how serious it is. Adverse effect is worse than side effect. Very good, all of them. All of them. With terbutaline, again, guys, it stops preterm labor contractions, but there are side effects and adverse effects you need to know. Let's talk about the side effects first. Tremors, jitteriness, tachycardia. And when I say tachycardia, I mean mild tachycardia. So your heart rate's supposed to be 60 to 100. Okay, it might cause your heart rate to go to 104, 105, not life-threatening, right? If we're in the 110, 115, now we're in adverse effect area. Chest pain, adverse effect. Dyspnea, adverse effect. Shortness of breath, adverse effect. Anything that has to do with your lungs where you can't breathe. Can you live without not breathing? No, that's going to be an adverse effect. And guys, that is it for this video. Please let me know in the comment section what you thought about this video and what you'd like to see me cover next. And maybe you really don't like this Kahoot format. You still want me to talk about these subjects, but maybe you want me to do a lecture on it, or maybe you want me to do a Q&A. Let me know, sound off. I cannot respond to everyone, but guys, I do see your comments. I try to respond to as many people as you can, but there's literally thousands of you and just one of me. But I do see your comments, and I will try to accommodate as much as possible. Okay. All right. Let's see how you guys did.